Hello everybody, I'm Jay Giri. I'm an interventional cardiologist at the University of Pennsylvania in Philadelphia. And we are here today with Vikas Aggarwal, joining me from Michigan, interventional cardiologist there, to discuss a novel therapy to treat chronic thromboembolic pulmonary hypertension called balloon pulmonary angioplasty. We wanted to thank the American Heart Association for commissioning this paper and helping us put together an expert group of international authors to weigh in on what the role of this therapy is today. Dr. Aggarwal is an internationally known expert in this field. He's leading the way in research. He's also educating really the world in how to perform these procedures. So I was honored to join him as a co-chair of this statement that he led, along with all of our other authors. So thanks so much, Vikas, for that. And with that, Vikas, I wanted to start by engaging you in what led to you bringing this up to me. I remember when you called me and you said, hey, I think we need to put something together to educate the country and really the world about this therapy that you're so passionate about. And I had mentioned, I think the American Heart Association is the perfect organization to go to try to educate folks when it comes to chronic pulmonary embolism. So what is balloon pulmonary angioplasty? And who are you considering as a candidate for this novel therapy?
So thank you, Jay. And I also want to thank the American Heart Association, you, Jay, and all the co-authors for working with us on this. It's a wonderful article. This balloon pulmonary angioplasty is a novel therapy that was really spearheaded by our colleagues in Japan. It was, an AHA journal, Circulation, that published a landmark article in almost 10 years ago now that showed that it's something that could be done for chronic thromboembolic pulmonary hypertension, aka chronic pulmonary embolism that leads to pulmonary hypertension. And I read that article and I was intrigued. I was still in training back then, and I took a journey out to Japan.
Wow. To
see what they were doing. And I came back excited, because I don't think it's that often that you come across a therapy and a treatment that you can help patients who essentially have no option in this day and age.
That's amazing. And I would say that to put that in perspective, when it comes to folks who are suffering from chronic pulmonary embolism, they may develop chronic thromboembolic pulmonary hypertension. A few % of them will develop that, and that's actually their blood pressures are high in their lungs. That's going to lead to clear morbidity and excess mortality. And then many more may actually be symptomatic, even though at baseline they don't have chronic thromboembolic pulmonary hypertension. And historically, we've got a drug for this that's been approved, riociguat, so there's a medical option here. But it's not perfect, right?
That's right.
And then we obviously have our great colleagues in surgery who can perform pulmonary thromboendarterectomy surgery, PTE surgery. And that I've seen patients, that's curative in some of those folks. But that doesn't work for everybody. Who doesn't that work for? Because that seemed like that, to me, was the gold standard.
That's right. So chronic thromboembolic pulmonary hypertension is potentially treated by both surgery and with medications, but surgery is not for everybody. It's a highly morbid, long open heart surgical procedure, and the surgeon can only take out the clots they can get to. And they can't get to the distal, more far out branches in the lungs. And those patients were pretty much being treated with the medication, as you said, so riociguat, which helps them feel better. Balloon pulmonary angioplasty has now been shown to not only make them feel better, but it also helps them with the high blood pressure in their lungs. In a lot of ways, very similar to surgery. So those patients who are otherwise not candidates for surgery can now be treated with balloon pulmonary angioplasty in most circumstances. The other population that it really makes a difference is those who still have high pressures despite having surgery.
Amazing.
And now they have another option, because you can't go through a surgery as morbid as pulmonary endarterectomy, also known as pulmonary thromboendarterectomy in some parts of the world, more than once. Another patient population that's really important to understand and know is those who have chronic pulmonary embolism, are symptomatic, but don't have pulmonary hypertension just yet. Those patients really don't have any medication option, because riociguat will only help you if you have pulmonary hypertension.
Interesting, yeah.
And those patients are essentially everywhere. Chronic thromboembolic pulmonary hypertension is the worst phenotype of this disease, but that's just the tip of the iceberg. Chronic thromboembolic pulmonary disease without pulmonary hypertension is this huge patient population that's pretty much going untreated at this time. So as a community can come together and have an option for such patients also down the road.
So what we're talking about here, to clarify for the audience as well, is we're talking about an endovascular procedure where you're going to obtain venous access, usually in a femoral vein, and then you're going to go up into lung vessels, and you're going to use the same type of equipment that we use for coronary interventions. You're going to send little wires through areas of lung arteries that are obstructed with chronic clot. And then we're going to open up those areas with angioplasty. And in these cases, it's often asked, oh, why don't you place stents? Well, turns out it doesn't look like stents are needed because this disease process is a little different than atherosclerosis. This is a disease of the lumen, whereas atherosclerosis is fundamentally a disease of the vascular wall. So there's this key difference. And it sounds like, Vikas, what you've elucidated for us is there's a few different populations at play here. Certainly those patients who are not great candidates for surgery are clear candidates for this. Patients who have gone through surgery but still have problems, especially if it's more distal clot, are candidates for this. Patients whose surgery is not technically feasible in the first place are candidates for this. And then the questions will remain on whether those groups expand, especially to that larger group of patients who deal with what we call residual pulmonary vascular obstruction without frank CTEPH. So this is really exciting, but it's not all sunshine and roses, right?
That's right.
Because it is an endovascular procedure. We're doing something pretty novel. We're in the lungs, and it's not always the most forgiving circulation as two of us do these procedures. So why don't you talk about what there is to worry about when you're taking on these procedures?
So that's a great point, Jay, and it's an exciting therapy, but it's also fraught with risks. The learning curve has traditionally been pretty steep because in the lung you are essentially trying to work around a bunch of air balloons. And it's just, in my mind, the most unforgiving circulation or vascular bed in the human body. You have to be careful. You have to know your anatomy. You have to know your branches and your blood vessels and where to go and where to not go. And that's exactly the impetus or the reason for a document like this from the American Heart Association. We don't want essentially everybody who wants to start this to go through the same steep learning curve that some of us have already gone through. We want to help people start these programs safely and successfully at their institutions. And a document like this will help you understand anatomy, technical details, as well as your procedural goals and post-procedural follow-up. The complication rates have come down substantially so over the past 10 years, which is promising, and which shows that it can be done safely. But we want everybody to use this document and to use the resources that exist to take this field even further forward.
Yeah, so the specific things that we run into from a complication standpoint include issues related to pulmonary hemorrhage, and it usually presents with hemoptysis. And obviously that can vary in terms of its severity, but it's important that folks recognize how to perform the procedures to minimize that risk, A, and then B, if, God forbid, despite those efforts, the complication emerges, how do you manage it? So that is some of the topics that are covered in the document that you led, Vikas. And it's interesting that this field is still pretty novel. You mentioned that they've been perfecting these techniques in Japan for over a decade. But here in America, in terms of comprehensive programs, it strikes me that there's only probably a couple of dozen active programs, maybe 3 dozen or so. Am I right about that?
That's probably true at this time, but there are, in the past 12 months, there are several centers who have engaged some of us and who have started, and more people are doing it, which is exciting and promising. So in my mind, it's a therapy that belongs within an expert, comprehensive CTEPH and pulmonary hypertension program. But if you have those resources, which are actually pretty well outlined in this document, you should do it. And we hope that at this point, we may have about 2-3 dozen centers in the country, but it may grow. It may be more.
That's great to hear. And just to be specific as we wrap up here, I would state that, and I think you agree with me because we've discussed this at length, that what you want to be doing if you're thinking about getting into this arena, especially as an interventionalist, is not thinking about it as your procedure. It's a team. It's a team that has to be built, and that team involves a lot of important players. Most importantly, it's going to involve a pulmonary hypertension specialist who's going to be able to think through what the appropriate management strategy is for an individual patient. Secondly, an expert thoracic surgeon, because you want to think through who can get surgery or not. And then finally, you want to be partnered with thoracic radiology because imaging is just such an important part of this. So these are the key 4 components to this. A lot more details in this great statement that has been commissioned by the American Heart Association. And we hope that we have the opportunity to serve patients better going forward because of it. Thank you so much.
Thank you.